How are you today, George?
I'm good, Glen. It's a lovely day.
All right. Hey, so I'm going to start by introducing myself, and then it's all over to you, basically. So my name's Dr. Glen Davies. I'm a GP in Taupo, and along with Sarah Hancock and Dean and Lee and Simon, we run a group in Taupo called Reverse Type 2 Diabetes Taupo. And in that group, we've had a large number of people that have completely reversed their type 2 diabetes. And in my practice at the Taupo Medical Centre, we've now had 78 people who have reversed their diabetes or pre-diabetes. So that's what, yeah, it's fantastic, isn't it? Because in the past, we've always thought that diabetes was this relentless progression to chronic disease, to retinopathy, to limb amputations, to kidney disease. And it turns out that that's absolutely, completely incorrect. And with the right diet and the right lifestyle combination, you can actually turn that around. It can prevent you from getting diabetes, but also it can reverse it if you do end up with diabetes. So that's what I'm all about.
Yes, and there are a lot of health conditions that are kind of on the fringe of diabetes as well. You may not have a diabetes diagnosis, but if you're close to it, there are many other health conditions such as cardiovascular disease that you can have, and this is an intervention that's not only for diabetes, but generally for the things that are associated with it, for the things that kind of come along with it.
Yeah, absolutely true. And so why I've been so excited to talk to you, George, is I read an article that you'd written with Dr. Catherine Crofts, and you were talking about how to support your immune system in this time of COVID-19. And what stunned me when I read that information was the things that stop you from getting sick from COVID-19 turn out that so many of them are also the things that stop you from getting diabetes and metabolic syndrome and all these chronic health diseases. And that was a real eureka moment. And that's what I'm really wanting to talk to you about. You know, like at the moment, we're all about COVID-19. That's where everyone's attention is. But in protecting ourselves against COVID-19, we're also protecting ourselves against diabetes and metabolic syndrome. And that excited me.
Well, yes. I mean, I would sort of clear that up a little bit, that you are still going to get sick, but these are factors that influence people's risk of being put on a ventilator and of being at risk of death. And so, you know, you're not going to be like bulletproof against COVID-19 if you take care of your metabolic risk factors, but it does seem to be that you will have a far lower risk of dying because you have it, or of you know, going into that emergency situation, and possibly of long-term complications from COVID-19, because with the SARS epidemic, there were some serious long-term complications in a lot of the people who survived it, who were close to death and survived it. That also is something we'll be looking at further down the track. So you're potentially protecting yourself against a lot of trouble in the future if you manage these risk factors.
Well, that's so interesting. And, you know, again, why I've been so excited to talk to you, George, is that, you know, as a doctor, I've still got a whole lot of questions that I don't know the answers to. And so I'm sure that the people that are listening to our conversation will also have a huge number of questions. And I'm aware that we'll be talking to some people who are very, very well educated in these topics, but also some people where this whole type of conversation is completely new to them. So, you know, George, you're a real brainy fella, and I'm going to get you to introduce yourself in a moment. So probably what I might do as we go along is I might ask you to put some of the things you say into a more layman's terms. So,
okay,
you know, being aware that we'll have a whole spectrum in the audience that's listening to us. So if you don't mind, if you're talking in real brainy fella language, I might ask you to clarify that as we go. But why don't you start just by introducing yourself, talk a little bit about what Precure is, and tell me why you've developed an interest in viruses and lifestyle medicine.
Okay, Precure a sort of private social initiative. So our business is teaching health coaches, is training health coaches in the kind of fluency with the health system, and especially with regard to lifestyle medicine, but within the health system. And my own particular, and providing, you know, some free services so that it, to increase the outreach of these ideas, which are basically the same ideas that you're applying. I became interested in this field and kind of, you know, got my start in it because I had hepatitis C for about 20 odd years, and so I'm sort of really coming from the position of living with a virus, and it's a very particular virus that does a couple of things that are, you know, a couple of things. One is that it causes insulin resistance. So you basically have a virus that's trying to give you a fatty liver, trying to give you diabetes. You know, this is kind of what you're struggling against, what the virus has done to your metabolism. And the other thing is that it is hijacking your immune system. So it's suppressing your immunity in some ways. It's giving you autoimmune syndromes as well. And so I ended up just trying to figure this out. At some point, I just thought, maybe there's something I can learn about this. You know, maybe there's some way I can make my life a lot more comfortable. Some shortcuts, you know, I can learn from science. And so I actually started looking at what was known about liver disease, what was known about Hep C and about viruses. And so I had quite a lot of experience of being kind of this live experiment myself, where I had to learn, first of all, how to interpret science, you know, because people are going to tell you all kinds of things, and a lot of them aren't true, and a lot of them might be plausible, but they're not, you know, they might be scientific, but they're not relevant, and so on. So you kind of I had to learn how to read science almost from scratch.
Just jumping in here, you know, already I've learned some things that I didn't know. I didn't know that hepatitis C caused fatty liver and affected the hyperinsulinemia, and equally, I didn't realize it had such a big impact on the immune system. So already I've learned a whole heap.
Yeah. So just trying to cope with and understand that situation and do something for myself, I ended up stumbling across, you know, a lot of stuff, and meaning that when I eventually got better from the hepatitis C, I was taking an interest in diabetes because I had these kind of insights that, you know, we're kind of generally lacking. And then when I came across the low carb literature, I thought, no, this is what I want. You know, this applies to what's happening to me. I tried it, it worked, it made me so much better, even when I still had the virus. Then I was able to treat the virus because they invented drugs for it that were very effective and safe. And I just went on and followed the interest in diabetes, and have, you know, since had a few papers published, and I've worked with Grant and Karen and Simon and Catherine and those people for a while now, and we've gone on, you know, researching the subject.
Okay, so just being aware that some of the people listening won't know those people. You were referring to Professor Grant Schofield?
Yes. So I'm referring to people who are on the pre-cure faculty, but also I have worked with them at AUT and written papers with them usually on diabetes and related subjects.
And then you said low carb. What were you referring to when you said low carb?
One day I was reading the Dr. Atkins books and just thinking about what I knew about hepatitis C. And I just came across something in Dr. Atkins where I thought, well, hang on, this is going to affect it's going to affect the viral replication. It's going to have an effect on the virus if I do this thing that Dr. Atkins is talking about, restricting carbohydrate. And I'll try this and see if it works, you know, just test it. How hard can it be? Tested it and found that I started feeling better, and that a lot of my symptoms started improving. And the further I went down that kind of low carb road, and no seed oils road is another part of it, the more normal I felt, you know, and I was underweight at the time. So that's why I'd kind of ignored that part of the Dr. Atkins book before. You know, I read it because it was interesting. It had stuff I wanted to know about vitamins and stuff like that. I'd always kind of ignored the low carb message. until I realized that it had nothing to do with my weight. You know, for me, it had nothing to do with my weight. There were other reasons why I would want to do this. I did it and actually gained weight. I actually got to 70 kgs where I am now, where I've been for the last 10 years, from about 63. So, you know, it's not a universal path to weight loss if you don't need to lose weight. But yeah, and it's worked very well for me since.
So we're talking about low-carb, healthy fat diets, and also ketogenic diets, and fasting also fits in there, doesn't it?
Yes, it does.
So that's what you're referring to, and just to do that very, very quickly, a low-carb diet is one where you cut out all of the sugars, but you're also cutting out carbohydrates, particularly the ultra-processed carbohydrates. You're focusing on having healthy sources of protein like meat, fish, and chicken, and you're eating above ground vegetables. That's basically what we're talking about, and we're cutting out the industrial seed oils such as canola oil and vegetable oils because they're inflammatory. So that's basically what you were talking about when you mentioned a low carb diet.
Yes, that's what I'm talking about, is that kind of version of the low carb diet, that you described just there. Yes, and you know, you can I eat some potatoes and things like that in sort of, so there's kind of three phases. There's a keto phase where you have no carbs. There's a lower carb phase where you maybe have kuma or pumpkin or something like that, and then there's also intermittent fasting, and so you have these sort of three things to play with, and the more urgent your need is, the more you're going to go to keto and to longer periods of fasting, the more urgent your need is. And then if you feel fine and you just want to manage that and stay feeling fine, that's when the low carb, high fat you know, allows you a bit more freedom, but especially if you keep the intermittent fasting, the time restricted feeding aspect of it. So yes, I've used all three of those strategies.
Okay, so that's fantastic. So let's get into it, George. My first question of you is, so we're in a type 2 diabetes forum. So why are we discussing COVID-19 here?
Because
why is it relevant?
Yes, there's two reasons really, and the first is that having diabetes or having those risk factors of the metabolic syndrome that go with diabetes greatly increases your risk of dying, becoming critically ill and dying if you do catch COVID-19. That's the first reason. The second reason is that you may well have reduced immunity because of those conditions and not handle the COVID-19 as well as a fitter person would, and you're just going to suffer, you know. And I don't want people to end up on ventilators, but I don't want them to be really miserable for a month, or you know, I don't want them to catch some infection that doesn't put them in hospital, but they don't get over it for months and months and months. You know what I mean? Because that sort of thing can really mess with your life. So I actually put quite a high premium on feeling comfortable if you do catch something as well. You know, and just kind of handling it like a healthy person.
Yeah, and we are actually talking about something significant here. Currently, the death rate is 5%. There's quite a lot of debate about the actual death rate. You know, we're seeing figures sort of from between 1.4 and 5%. But whatever it eventually works out to, this is a significant illness that we're talking about, yes. And something that we all need to be taking very seriously.
That's right, and you know, the arguments about the death rate become moot as soon as the capacity of our hospitals is overloaded, because then people die at a higher rate, and they die at a higher rate of other diseases. So we have to bear that in mind. Really, what we're trying to avoid is putting a stress on the health system that will allow that will kind of expand the death rate. That's what we're trying to avoid at the moment.
Okay. Now, my next question is, so we've heard a lot of talk about COVID-19. We've heard talk about influenza. We all know about the common cold. You've just talked about hepatitis C. We've heard about SARS back in 2008, 2009, and then MERS. You know, what's the difference between catching COVID-19 and catching influenza and catching a cold? Why are why are we so more worried about COVID-19 than we are about catching a cold? They're both viruses.
Right. Well, first of all those diseases that you've described are RNA viruses. What they have in common is that they use the RNA and not the DNA, and they're not like HIV, they're not reverse transcription viruses, they're straight RNA viruses, I believe. Now, they fall into a group of families. So hepatitis C is in the Flaviridae family, and SARS and MERS and half the common colds that you get are in the coronavirus family, as is the new one. And influenzas are in the influenza family again, and they tend to be categorized by the way they attach themselves to cells. So it's the outside of the, so we categorize flus by H1N1, H2, blah, blah, which is our description of the outside proteins. And the same with coronavirus, it's the spikes, the crown on the virus that we name it after. Now, what happens is that these coronaviruses they're endemic in humanity, and probably the traditional cold viruses can kill people who've never been exposed to them before, and this is what you saw in the colonial period. Is that some island that had never had contact with the places the old coronaviruses came from, that were just colds that people didn't even know they had. They just had a runny nose. They went to somewhere like Tahiti, and maybe people who got it, a few of the people who got it started dying. Not as bad as say the smallpox or the big killers, but the TB and that were brought with colonization. But certainly there were people who were not used to these viruses. So that's what happens when something is novel. When the immune system doesn't have a memory of it, and you haven't inherited some memory of it perhaps, and you haven't got the memory of it from having had it before. And so SARS and MERS, well, if we go back earlier, we have the Spanish flu, probably an influenza virus. People debate about what it was. And then we have, in 1968, there was the Hong Kong flu. This killed 1 million people around the world. This was a new flu virus, and I had it, and it was really horrible. I still remember what it was like. And then we had swine flu 40 years later, and SARS and MERS didn't really get here to any great extent. I think MERS died off pretty quickly, and SARS did kill quite a few people around the world, but I don't know that they got to New Zealand. But these were both coronaviruses, and they were novel coronaviruses. So what happens is that the coronaviruses, they kind of can be picked up by animals. We don't get infected by them, but they can be picked up and exist in animal populations, and usually not a huge problem, but sometimes they can mutate and they think that coronavirus mutated, the SARS coronavirus mutated in a civet.
What actually is that? What's a civet?
Civet is a kind of a cat-like animal. It's kind of like a cat or a raccoon. They make coffee from it by feeding it the coffee and getting the coffee out of its poo. It's called copiluwak. So that's actually a thing. It's a thing, but trust me, I've never had it. It's like very, very expensive. And you also get scent from civets, and I believe they're probably eaten as well in China, where a wide variety of things are eaten. And so that's where the SARS virus comes from. The current one possibly went through a bat, but one of the interesting features here is that these mutations tend to occur, or seem to only occur, in areas where soil selenium is very low. Coronaviruses and influenza, I think all RNA viruses that I know of, use a lot of selenium in their own structure to protect the genome. So if you think about the selfish gene theory, evolution is all about protecting the genome. Things don't want to mutate if they can help it, because the preservation of the genome is just kind of what an organism is for. And so RNA viruses have evolved to use a lot of selenium as kind of an antioxidant defense to prevent the genome getting mutated. And in low selenium parts of the world, such as Wuhan, that's where the SARS came from last time. And so you have this thing of human and animal kind of interaction across a lot of species, but you also have the low soil selenium making it more likely that a virus can mutate. So that's one of the factors, and that's one of the nutritional factors is when you have a place which is very low in selenium, the possibility of a virus mutating and becoming more virulent, and also affecting people more because it's taking away selenium from their bodies as it does its thing. And coincidentally or not, northern Italy is a very low selenium region as well, as Wuhan, or Hubei province, I should say.
So just aware that some people who are listening to us might not have heard of selenium before. Where do we get selenium from in our diet?
It's going to be in any multivitamin that you find in New Zealand in a way, made for, sort of made for New Zealand conditions, because we are so low here. You're going to find it in Brazil nuts are the best source. There will be some in meat and seafood and so forth, because animal feed is supplemented with selenium to make sure that they get enough to keep them healthy. And there are a few other things. I think we get some from grain and legumes and things like that. And if these are imported, there will be more than if we grow them here. So our selenium level went up slightly after sort of Rogernomics, when we started importing more of our food, because we were getting some of it from places with higher selenium levels. But it's still it's still borderline in New Zealand, so it's something worth looking at. Brazil nuts are the obvious quick fix.
And I think it's something like 3 Brazil nuts a day. Is that about right?
Yeah, Brazil nut has about 19 micrograms of selenium. That's the one sold in New Zealand. So 3 would take you to an optimal level, yes.
Okay, so 3 Brazil nuts a day keeps the coronavirus away?
Well, no, but it may give you some protection. There is some improvement in survival when they give it in these RNA viruses, when they give it as a supplement. But I think the main thing is kind of a population benefit of not having it mutate into some new form that's going to be worse for people. Because you can certainly show this in animal experiments, that if you feed a virus through a chain of infection and it goes through animals that are depleted in selenium, it becomes more toxic to the other animals, even the ones that aren't depleted. The changes that happen to the virus are not good. You want it to stay the same, because that means that everything you've learned about it, everything your body learns about it, is still working on it.
Geez, it's so absolutely fascinating, and I'm blown away by your wealth of knowledge, George. You must spend a lot of time in front of journals and learning all this stuff.
Yeah, it's just curiosity. I just can't help it. I just can't help but read the sidebars, read the references if they're interesting.
And it's the science at the moment that we're all learning. Like, we've all learned a whole new language in the last 1 to 2 weeks, haven't we? And it is absolutely fascinating. I know it's frightening, but equally, it's absolutely fascinating and completely interesting.
Yeah, I think, at the end of the day, it can probably all be boiled down to a few relatively simple things. So we'll see what happens at the end of this. We'll see if we can get there, because I think there's a few relatively simple things. And one of them is just to be well fed. That selenium example shows you, all essential nutrients are essential for the functioning of our immune system, as well as everything else they're essential for. And malnutrition impairs our response to new pathogens. And so that's one factor, and it's not the only factor, but it's a very simply be well fed,
So let's just talk about that, because when people think about malnutrition, I guess the image that comes into our mind is starving children in Africa. But that's not actually the malnutrition that we're seeing in the Western world, is it? We're seeing a different form of malnutrition.
Yeah. For example, if you get all your energy from grains, which many people do, there's practically no magnesium in grains. A loaf of bread is practically no magnesium. If you ate a potato, you'd be getting plenty of magnesium, or some magnesium, and ditto for potassium. So, you can get lots of energy in that way, but there's some things that you're not going to be getting. And this is, becomes, as you move on to kind of whole food and whole fruit and veg and especially whole animal products, then you're getting to foods which are going to have a little bit of everything you need in them. But that's not the case for refined foods. And so, we have to be aware of that. So you can be quite well fed, but you can be, have it have a deficiency somewhere, obviously, or have what they call a subclinical deficiency, which is the deficiency that may become obvious if something starts to make a demand on that nutrient, which would be the case with selenium. If the virus starts making a demand on it, you may have had no health symptoms from your level before, but now it's going to drop to a point where you need it, yes.
And you could also be overweight and malnourished.
Definitely. Definitely, yes. I mean, that's, especially if you're say under-eating protein, overeating energy, that sort of thing, you are, yeah. I mean, that's very possible. I mean, there are some deficiencies that prevent you gaining weight. So a deficiency of vitamin B1 will prevent you gaining weight, but not all deficiencies are like that.
And I think probably what we're seeing in the Western world at the moment is we're seeing a lot of people that are overnourished in terms of energy, but undernourished in terms of nutrients.
Yes, and another thing is that the excess of energy can actually keep nutrients out of your cells. So if you have, say, too much triglyceride in your blood, that's going to dilute fat-soluble vitamins, things like vitamin E and vitamin A in your blood, make it harder for them to get into cells. And if your blood glucose is too high, that's going to make it harder for vitamin C to get into cells. So vitamin C doesn't really work properly in people with diabetes. It's competing with glucose. So as long as the glucose is high, the way the vitamin C is handled in the body is not normal. Even if you give someone a supplement, it doesn't do quite the same thing in the cells that it would be doing if glucose was lower.
Wow.
So yes, the energy excess can actually create the micronutrient deficiency in practical terms sometimes.
I knew I did the right thing by asking to talk to you, George, because I've already learned so much. But moving on now. This is one of the things that I really want to understand. So, are we like 100% vulnerable to the coronavirus? If somebody coughs and we get one of those droplets and we inhale it, are we 100% going to get the virus? Or is the other statement true, that if our immune systems are strong and we're well nourished, could we be exposed to friggin' litres of coronavirus and not get it? What's the truth? And I know the answer is going to be somewhere in the middle, but I just don't have a concept of this.
I think the answer is much more true that you're going to get it. There's a 100% chance that you're going to get it. But what you do with it will determine whether you, whether it kind of makes itself at home in your body, whether it causes problems for you, even potentially whether you can pass it on. So your immune system, if you have a very small exposure and you're very healthy, your immune system can get on top of it relatively quickly, keep the numbers really low, so you may be less able to pass it on and so forth, certainly keep you from having symptoms like cough that pass it on. But it is going to make an impression on you. So you'll be able to find the antibodies later. So it's not that you can be bulletproof to it. But that said, I think an important thing that has kind of been missed in this discussion, although health professionals who are at risk, the ones who are actually dealing with the cases know this, is that it really matters how much virus you get when you get a virus. It actually matters how many virus particles hit your immune system at first, because if you're going to get on top of it, it's easier to get on top of it if you're not swamped with this new thing, and so things like masks that may not give you perfect protection at all, like half the virus particles may get through, but that's still reducing exposure every bit, every barrier. So every time you wash your hands, disinfectants only kill 99.9% of germs. There's still 0.1% of germs. So you can still potentially get an exposure, but it's going to be a smaller exposure. And small, the reason that, for example, some healthy medical professionals have died because they have been exposed to seriously ill people with coronavirus without protective equipment. It's a numbers game. It's about very large quantities of virus overpowering immune systems that perhaps could have coped with smaller exposures. And I think that's something we kind of have to appreciate, especially when the lockdown ends. It would be a good idea if people still wore masks. It would be a good idea now if people wore masks to the supermarket, not because it gives absolute protection, but just because it reduces that exposure.
All right. Thank you, George. I've I've just been moving my notes in the background. So just to summarize that, your feeling is that if we're exposed to the virus, the virus is going to enter our system and interact with our immune system. The question is, will we get sick from it? Or will we just have a minor illness? And the reality is that most people, the vast majority of people, are having a minor illness, aren't they? You know, we're getting, I think the statistics, recently we had 13 people in hospital and 1 or 2 in ICU. So the majority of people, the 800 people that have been exposed, are at home managing it like they would a cold or an influenza.
Yes, or they don't even know they've got it. And you can clearly see that the pattern with young people having less, it affecting them much less, and age being a large factor, is to do with the speed of the immune response. Young people have very strong immune responses that go off at the slightest alarm, and old people tend to get sluggish immune responses, and people with metabolic diseases get sluggish immune responses. And now, with some illnesses, this fast immune response actually makes young people more vulnerable. But luckily, that's not the case with this. This is actually something where you can kind of clearly see that, yes, you want to have a working immune system. That's not going to catch you out. That's not going to be something the virus can use against you. In this case, it seems that these sort of fast immune responses get on top of it in time. And the real danger is that you'll have a overactive immune response that's too slow. If you have the immune response by the time the virus is kind of well seated in the lungs and it's managed to infect lots of lung cells, and then the immune system finally wakes up and goes, tally-ho, that's when you get the cytokine storm. That's when you get too much sort of battle being fought in the lungs for the lungs to be able to survive. And so yes, clearly these early immune responses are a good thing.
Okay, now there was a whole lot of complexity in what you've just said there, George. So I'm just going to see if I can summarize that, and you tell me if I've got this right. So you want to have a good early immune response to the virus, and people who have a sluggish immune response, that allows too much of the virus to replicate within the body and infect the lungs. And then we've got this other end of the spectrum where people aren't mounting an immune response at all, but then they mount this dramatic and sudden response right at the end, and that's what contributes to this adult respiratory distress syndrome, which is part of the reason that people are in ICU and on a ventilator. So you want an early response. You don't want the delayed, exaggerated response.
That's right, and I think a valid parallel here, a valid analogy is the phase 1 insulin response. So a person who is insulin sensitive, they eat carbohydrate, they have a strong phase 1 insulin response. Within 30 minutes, their insulin has pretty much done its job, controlled the blood glucose. And in type 2 diabetes, the phase 1 response is delayed and weak. And as a result, you get this really high phase 2 response, and that's where hyperinsulinemia comes from. And so I think that's a good analogy, the way that a normal person responds to glucose and kind of like reacting quickly and getting it out of the way. And to prevent that later rise in insulin that we know is harmful is I think a decent analogy in this situation, even though it's dealing with a much more simple system.
All right, I really like that. Okay, so what then are the factors that are going to stop us from getting unwell if and when we're exposed to this virus? What could you even list them from what you reckon is most important to less important?
I think this kind of exists on 2 levels. So there's one, what are the factors that are going to actually stop you from dying or being at high risk of dying? Because even people at the highest risk, some of them are surviving, and some of them probably not even getting sick. So you can't just say that this is, kind of hard and fast rule, but you definitely got a lower risk of dying if you don't have diabetes, and which is diagnosed as a blood sugar level, pretty much. And you've got a lower risk of dying if you don't have hypertension, and you've got a lower risk of dying if you're not obese, even if you don't have those other symptoms, other things. Obesity is emerging as an independent risk factor, and there's a few less common things like immunosuppression and other serious illnesses. It's hard to tell from the statistics how important they are, because the majority of risk is being associated with diabetes, hypertension, obesity, and cardiovascular disease, which are all related conditions. As we know, these are all the conditions of hyperinsulinemia and the metabolic syndrome.
Yeah, so that's really where I was wanting to go to next, because you've basically just described metabolic syndrome, and you've said that relates to high levels of insulin in the body and insulin resistance. So these factors that are important for this chronic disease epidemic that we've got. And I don't want to make the COVID-19 sound less important, but we've got a 5% death rate, or a 1.4 to 5% death rate with COVID-19. Yet with this metabolic syndrome that you've talked about, caused by high insulin levels, they're saying that 88% of American adults have some form of hyperinsulinemia and some form of metabolic syndrome. So, we're looking at a massive epidemic of chronic disease and metabolic syndrome, which really is the huge topic.
Yes, yeah, and it's a lasting topic. That's the one that's not going to go away, because this is going to go away. I mean, I think we'll be living with the traces of this for decades to come. I think there will be health checks in airports in 20 years' time, the same way there's still security checks in airports now, 20 years after 9/11. I think that's, or whoever, sorry, 10 years after, but that's, sorry, no, yeah, no, that was 20 years almost. So I think we are going to have these lasting effects, and the disease will come back from time to time. It'll probably be part of the standard flu and cold season for a while. But the metabolic disease is going to stay. It's going to be around, and we're going to be dealing with that long after this has stopped being a topic for discussion.
I don't know if you know the answer to this question, George, but because in the United States, the hyperinsulinemia is affecting 88% of adults, are we seeing a different spectrum of disease in the United States, particularly in New York, specifically because people are more metabolically unwell?
That's really impossible to say until there are statistics about case rates and proper reading of the data to see what people, because you to answer that question, you really need to look at the last blood test a person did when they were healthy, and then correlate that with the outcomes when they got the illness, and that's a long way away, that kind of research. But I mean, it seems reasonable from what we know about the risk factors that a country with a high rate of both obesity and diabetes like America is going to be really hard hit, and that populations with higher rates, specific populations that have higher rates, are going to be harder hit, and so on. But we could find some exceptions. We could find pockets of protection within these things, and then we'll have to within these risk categories, and then we'll have to wonder why that was, and so on. So we'll see. But it definitely seems like it's it is highlighting the importance of these conditions, definitely, when you read the statistics.
So just an aside here, is COVID-19 the name of the virus, or is that the name of the disease?
COVID-19 is the name of the disease, but almost no one uses this language, because the World Health Organization or the Center for Disease Control, I'm not sure who came up with it, but I think they kind of mucked up, because they called the disease after the virus, and they called the virus after the disease, which is kind of counterintuitive. I think the virus is called something like coronavirus SARS-2. but SARS is a disease. So they've named the virus after the SARS, and then they've called the thing coronavirus disease 19 is a name for the syndrome.
It doesn't really matter.
It doesn't really matter. No, it doesn't really matter. I'm certainly not going to pull anyone up if they use it interchangeably, because I do, and you know, we know what we're talking about. If we're referring to the disease, we're referring to, you know, usually in the literature, ARDS is the acute respiratory disease syndrome. So the kind of the SARS equivalent of this is called ARDS, and the COVID-19 infection or novel coronavirus infection.
Okay. Now, at the beginning, I mentioned this amazing paper that you'd written with Dr. Catherine Crofts, and there was some fascinating references in there to the blood sugar that people had, and how the blood sugar seemed to determine whether they were going to get really sick from the coronavirus or not sick from the virus. Can you talk about that?
Yeah, well, these are people turning up in an ICU, or turning up in hospital anyway. So they're already pretty sick, and this is the data from Wuhan, and the mean blood glucose level of the people who went on to develop the acute respiratory syndrome was 7.4 millimole. So they were in the diabetic category. Under the people who did not develop the acute respiratory distress, the people who did not need ventilation, their mean blood glucose was 5.4, which is a millimole, which is a perfectly normal blood glucose. Now, so you could say, well, some of this is probably due to the effect of the virus itself raising blood, you know, the immune response raising blood glucose. And I think, yeah, there's probably some truth in that. But these are people who are sick, you know, they are in hospital. They're not people who've had no immune response yet to the virus. They're people who, you know, who've kind of got the whole inflammation and that going on. So, and there are a number of other reasons to think that the glucose is a factor, because of the way the virus interacts with HbA1c. It interacts with hemoglobin. So the less functional your HbA1c is, the more damage it can do. And
this is
because
to
we know
do
that,
with glycation, isn't it? This is due to glycation of the hemoglobin molecule.
Yes. So the virus does interfere with the hemoglobin molecule in a way that would predict that having more glycated hemoglobin wouldn't be good. And I mean, because you need hemoglobin to breathe. You know, hemoglobin is how you get the oxygen around your blood and into your cells. And so it's, yes, you know, so yes, it can be critical at this point. Yeah.
And then there was another really interesting point. You were talking about LDL cholesterol as well.
Yeah, yes, and this is very interesting because you had higher people who came into the hospital with higher LDL cholesterol were less likely to develop the acute respiratory disease syndrome, and it went down even more when they got it, and the people who died had the very lowest LDL cholesterol. And now this again could be a function of the disease, because inflammation tends to divert cholesterol synthesis into making something else. So instead of, you know, it does, having a very inflammatory disease can drop your cholesterol. That's true, but you know, the higher it is when you start, the higher it's going to be after that drop is one of the factors. We do know that high cholesterol, and especially high LDL in people over about the age of 60, is not associated with mortality. Sometimes it's protective, and it's associated with less infectious disease mortality and respiratory mortality. And some people say, well, this is just because older people with high LDL are probably just better fed, you know, better nourished. And I think there's some truth. I think there's some truth in that. But there's a couple of reasons why the LDL itself can be protective. One is that it tends to attract sort of pathogen material in the body and allow it to be cleared. So it's kind of, but it's more especially the HDL does that. But this possibly LDL can too. And the other is that a protein carried on the LDL called ApoE, which is goes in several forms in humans, but ApoE is actually protective of lung function. It's a kind of an antioxidant protein in the lung, I think, and the same with the ApoA1, which is on the HDL. So there are these two proteins carried in the circulation by lipoprotein particles, which are actually important in lung function. And all the things that we say about the triglyceride HDL level and the HDL functionality with regard to metabolic disease are actually true for lung disease. Actually, HDL has this important function in the lung, which is in some ways related to the function it plays in the arteries, and metabolic disease interferes with this function.
All right. So when doctors in the past have referred to LDL cholesterol as bad cholesterol, that's probably a bad description, isn't it? Because from what you're saying, LDL has an important function in the immune system.
Yeah, yes, it does seem to. It does seem that one of the one of the good things about LDL cholesterol is this somewhat reduced risk of dying of things that aren't cardiovascular disease. Because when we focus too much on cardiovascular disease, we say we have to get this disease down. We don't care what we do to get it down. And then we start, pushing up rates of diabetes and so forth because of the strategies we've used to get it down. Because, of course, it's easy to get LDL cholesterol down just by eating carbohydrate. But that's not a good substitution for all the other risk factors that go with it. So when you, when you just focus on one possible way of dying and ignore all the others, you can end up in this kind of situation where you've made other things worse quite easily.
All right. Now, I think the final question I want to ask you is, after all of your extensive reading, what are you doing to support your immune system so that you are less likely to become unwell? So just before you do that, I think it's important that we repeat the public health messages, yes, because that obviously is the most important and clearly the most important way of not getting sick in the first place.
That's right.
So the public health messages which we've been, that's about social distancing, that's about covering your cough, that's about not going to work if you have a cough, and recently some interesting stuff that masks are probably going to reduce the chance of spreading the illness and may to some extent protect you. So all of those things are so very, yes, very important. Yes. And
wash your hands. Wash your hands if you need contact with the outside world. So if you've been to the supermarket, got some shopping, what I do is I wipe down some of the shopping with disinfectant spray, put others in soap and water. You can't wash everything, but I wash as much of that stuff as I can. I wash my own hands. I actually keep I keep water and soap in my car so I can wash my hands if I'm out. So if I fill the petrol from the petrol pump, I can just wash my hands before I even get back in the car. So on the principle that every bit helps. And now, are there other things you can do to stimulate your immune system or to keep your immune system in that sort of young person's immune system state where it's going to respond quickly? Well, I started looking into the literature for herbal supplements simply because I found these effective in the past. I found them very effective when I had the swine flu, the elderberry, and generally if I've got these things and I use them when I've got a cold, I feel better. And so I just wanted to know, and I tend to do better than the people around me as well. So I just wanted to know, it's easy to say that because that's my experience, but can I convince someone else? Well, then you need the science. So I read the science, and the science on the elderberry, it looks great. In an experiment, it'll raise your cytokine levels, which is what you want when you first get an infection. That'll help you avoid the cytokine storm later on. So and you have very good results of decreasing the number of colds and flus, but the number of people in those studies, it's only about 180 people. And it's very hard to convince people in this sort of hard-headed science world that something that's worked in 180 people, say a low-carb diet, if there'd only been a trial with 180 people in the low-carb arm, it would be very hard to move anyone's kind of opinion on that. But it all fitted together with the animal experiments, with testing around vaccines, which I think is a good sort of, when you vaccinate someone, you're trying to imitate their first response to a new disease. and so things that boost that aren't actually the vaccine are called adjuvants. And so these herbs do seem to have an adjuvant effect that's quite noticeable. But anyway, while I was reading this, I was always looking in the sidebar, which will always come up with other suggestions, related topics. Here's a related paper, a paper that, you know, cites this paper and so on. And I'll keep seeing probiotics in the side. And I'm like, well, probiotics are last year's news. You know, everyone knows about probiotics, you know, but I thought, I'm going to read these. And I looked at them and I'm like, wow, this is actually a really solid and large body of evidence. So now you have lots of trials. You have thousands of people, and you have also a number of very rigorous vaccine trials to see whether probiotics help people respond to vaccines. And they do so consistently. And in the case of flu, and importantly, they also work for elderly people. So a lot of this research is in children, because it's children that usually vaccinate. And so when you give children probiotics around the time they're being vaccinated, they are more likely, they'll have higher antibody levels and other signs showing that they've more likely to have had a proper lasting response to the vaccine, which is what you want. So you're increasing the coverage that you get from a vaccine, because a vaccine never works for everybody. So you're trying to get herd immunity by vaccinating as many people as you can, so that if only 30% of them are immune, that's enough, you know, or however well the vaccine works. In older people, when you're giving things like flu vaccines, of course, they don't often work because the older person has the more sluggish immune system. So when you give a elderly person probiotics along with the flu vaccine, you have a sort of a doubled rate of what they call seroprotection. So that's of immunity actually turning up after the vaccine. You're roughly doubling the chances that the person is actually going to be immune to those particular flu strains from the vaccine, which is a very important advantage. And so what?
Just to stop you for a second there, George, doubling the response is really dramatic.
Yeah, yes, it is. It is, and you know what this means in terms of protection is, with the COVID-19, is that some people are getting it but not becoming immune to it. So the possibility of reinfections there, which means the possibility of the virus hanging around for a long time, is there. So possibly one effect of, so when you give people probiotics, you know, without the vaccine, and they're just taking probiotics in a trial, they have about a 40% lower rate of upper respiratory tract infections. And the vaccine research suggests that some of this protection is from recurrent infections that aren't coming around again because you got immunity the first time. That would be consistent. Very consistent with the vaccine effect is that there would be more lasting immunity and less reinfection during cold and flu seasons. So that could account for part of that effect, and part of it could be due to just a more prompt immune response to the virus, so that the person has less symptoms, and so they don't know that they've got a cold or flu, so it's not even recorded. And it's probably the most, because this is from a Cochrane review, and Cochrane reviews are very skeptical about the standard of evidence, and so most of it's low or very low, which I don't think matters with the large effect size and the reasonably large number of trials. But but one of these findings has what they call a moderate grade evidence, which is actually pretty good and in the context of a Cochrane review, and it's for antibiotic use. And antibiotic use is quite a robust finding, because a doctor has to write the prescription. He has to think you need antibiotics, and so an antibiotic, you know, if you need antibiotics after a cold or flu, it's been quite a serious one too. It's not the average treatment for cold or flu; it's a complication of a cold or flu that's done a bit of damage to you. So,
and George, can I just stop you there and just make an important point? Is that antibiotics don't treat viruses. Antibiotics are treating the bacterial complication of the viral illness, aren't they?
Yes.
So,
yes.
Just an important point, because in primary care we're very we're repeatedly making the point that you can't treat a viral illness with an antibiotic. So I'm just wanting to clarify that point. We're talking about the bacterial lung infections, which complicate the initial viral illness, aren't we?
That's right. And the probiotic use reduces and it's the best evidence in these trials is that probiotic use reduces the need for antibiotics after a cold or flu. And if you do need antibiotics after a cold and flu, it's because that was a particularly bad. That's not the average cold or flu. If you end up with a bacterial complication, it's been a bit tougher on you than on the person that didn't need that. I mean, I know I've had pneumonia after cold and flu, and after a cold, and it's definitely a sign that it took it out of you.
And then just for people in our audience that may not be familiar with probiotics, where you can buy probiotic capsules, but you can also get probiotics from foods such as fermented foods, such as sauerkraut, from yogurt. So we're talking about both foods and capsules, aren't we?
Yes, I think by extension, this goes over into probiotic foods such as high quality yogurts and sauerkraut that hasn't been sterilized and this kind of thing. But we can't exactly say that it applies to those foods. It's using particular strains of probiotic, usually the Lactobacillus rhamnosus, LGG, and the bifidus, and these are the common ones that you buy when you buy a probiotic, and they're usually very close to the strains in yogurt and so you could say yes, fermented food. And also another factor is prebiotics. So one or two of these trials, of the vaccine trials, used prebiotics. They didn't even give a probiotic, they just gave probiotic food. They gave the type of fiber that probiotics really like. And this also had an effect. So it's so it's generally pointing towards some kind of possible preventive protective effect of a whole food diet, a kind of a whole real food diet with some fermented food in it. But if you wanted to be certain that you were imitating the research, you would use one of these kind of standardized probiotic strains that are actually the most common ones you can get. They're not that hard to find.
All right. So George, thinking we probably need to wrap this up now. So let's see if we can provide a summary from what we've said. So as a test to see whether I've been listening and understanding you, I'll have a go at that. So what I've understood, you've indicated that if we get exposed to the COVID-19 virus, there's quite a high likelihood that we're going to get the illness. The question is going to be, are we going to get a mild illness or are we going to get a severe illness? And how our immune system responds to the virus is really a large part of what determines whether it's going to be a mild virus where we can stay at home and we recover, or whether we may be in this smaller group of people that get the severe illness and may need to be admitted to hospital, may even end up on a ventilator, and worst case scenario may die from it. So there's some things that we can do, and the interesting thing you said is, first of all, make sure that the amount of virus that we're exposed to is less, because if we are exposed to a large amount of virus at a small or in a short period of time, we're more likely to get a severe illness. And so that's the logic of wearing a mask and ensuring that our social distancing is there. And then you've talked about some factors that are going to make us less likely to become severely unwell. And the first thing is, if we have got metabolic illness, doing something about it. So we know the things that help with that are managing our blood sugar, and we do that with a low carbohydrate, healthy fat or ketogenic diet. Also making sure that we get enough sleep, because sleep is powerful in both preventing metabolic illness but also improving our immune function. Moderate exercise, and doing no exercise is a problem, but equally over-exercising can be a problem for our immune system. So getting the exercise just about right. And something like a brisk walk for 40 minutes every day would be a
Yeah.
good example of moderate exercise.
Yeah, and my advice would be that if you have a cold or flu, don't go and really strain yourself so you have to breathe heavily, because you don't necessarily want to be breathing stuff from your throat and your nose deeper down into your lungs. And I think I've given myself a hard time doing this in the past, where I've been like, oh, I'm all right, and I'm all right enough to play a game of football, and I'll be healthier after I do it because of the exercise. And actually the opposite is true. I went right back to being sick again. So
yeah,
be aware of that airway kind of flow factor in the exercise you do, I think. But yes,
and then stress.
do keep moving.
Stress has a negative. Well, a small amount of acute stress can actually be beneficial, but chronic long-term stress can be a problem for the immune system. And at the moment, we're being exposed to a large amount of potentially distressing information through the news. And so I think if people are feeling overwhelmed by the amount of information they're getting, there's probably a responsibility to manage the amount. So managing stress, I think, is important.
Yeah. I mean, I think it's very hard to say how stress is going in this situation, because it's stressful for some people, but it's actually deeply relaxing for other people, and it's not necessarily what you could have predicted. So yeah, I mean, but definitely, turn off the TV sometimes. You don't need to know today's score. It's not as there was some like crazy conspiracy theorist who I actually ended up watching one of those videos, and God, it was appalling. But he did say one thing that I thought was true. He said, "Stop watching the score. It's not a game." And I think, there's people like us, we need to know the score, but you don't really need to know the score every day. You don't really need to keep up to date with that. You might need to keep up to date on if any rules have changed. If there's a shop that you wanted to go to that you thought should have been open, you might find that it is actually open now because you were right about that. But that sort of thing is there are things you need to know, so keep in touch, with the government. But in terms of kind of keeping an eye on it, there's lots of people who've got that responsibility now, and if you want to take a day off, do.
Yeah. So diet, exercise, sleep, stress management, and then there's some specific things which you've spoken about that I found fascinating, particularly the probiotics. So if you can access probiotics at the moment, fantastic idea. But if you can't, the prebiotic and probiotic foods would be a fantastic option. And then you've spoken about selenium. So selenium is in Brazil nuts, but it's also in all the multivitamins.
Yes.
If
you've got a multivitamin in the back of your cupboard that you bought, on a rainy day, it's like a Centrum or something like that you bought, and you've never bothered to take it, now it's probably a good time, I think.
Yeah. And you've spoken about vitamin C. And I know in the past we've talked about the literature being a little bit uncertain about oral vitamin C, but certainly it's not going to do any harm. So your multivitamin and multi-mineral is probably a great idea at the moment. So is that a reasonable summary of what you've said?
Yes, that's a reasonable summary of what I've said. And I also think that that the herbal antivirals of the elderberry, echinacea, and andrographis sort, which if you have those and you like them, they I think they're worth taking. But the evidence for them is not as strong as the evidence for probiotics. But that's also because it's just not as well researched. We get the research that we pay for, and if people aren't interested in something, they don't pay for it. And it takes, as we know, $1 billion to research a drug enough to get it to market. And so there's no wonder that research on these things is thin, but it always pays, I think, to read the animal research. If you see like quite amazing results in animal research, they're probably there for humans, to some extent, if you can kind of find the same conditions. But weak results in animals translate to weak results in humans, and if the results require, you know, a toxic dose of something, then, you know, that's obviously ridiculous and so forth. So you've got to interpret that stuff with a grain of salt. But I think, well, yeah, I think the point I would make is that the most popular herbal antivirals do work on much the same pathway that the probiotics work on. They're doing a similar thing. And you may well think, well, the probiotics kind of the more natural way of doing it, and so forth. But I mean, it depends on your own experience with these things.
Okay, and then just to finish it off, as you alluded to, some people have got some extra time at the moment. I would be suggesting, if you are somebody with type 2 diabetes or metabolic syndrome, or you're overweight, now would be a fantastic time to be looking at low carb, healthy fat and ketogenic diets, and see whether that is something that you might like to take on. What's really fascinating in the supermarkets at the moment, there's no restrictions on vegetables, there's no restrictions on meat, fish and chicken. The restrictions are on flour and pasta, aren't they? So what better time to be starting a whole food, low carb, healthy fat diet that excludes the ultra processed foods, learning about type 2 diabetes and how you reverse it. You know, buying some of these books online and looking at some fantastic YouTube clips. You know, like YouTube's my go-to when I'm starting to research something. And there's some amazing stuff on YouTube on low carb, healthy fat diets. If you've got some spare time at the moment, maybe instead of Netflix or Lightbox for a night, spend some time on YouTube and look at some of this information on low carb diet, ketogenic diet, intermittent fasting. There's some fantastic resources, and what a wonderful way to spend this period of time where we've been given a little bit of extra time.
And I'll just talk about intermittent fasting a little bit, because you can, you know, a lot of people will be restricted in their food choices. They'll have what they have. They'll have whatever the supermarket's got or whatever. So they'll be like, oh, I can't do this because I've only got this in my cupboard. But intermittent fasting allows you to get some of the benefits of, and for just fasting in general, allows you to get some of the benefits of carbohydrate restriction, even when your diet has a bit more carbohydrate in it. So that's a good option for people who think their food choices are too limited to try this now. And although you'll probably find they're not if you once you read a bit about it. And the other thing I want to say is that Michael Mosley had an interview with Kim Hill this morning. He was mostly talking about his book about sleep, but he had some excellent stuff about COVID-19 to understanding what it does, and you know, and the possible role of sleep in immunity. So look up for that. Look for the podcast of that interview with Kim Hill and Michael Mosley. If you
George, I do actually want, one of the risks, I think, at the moment, apart from catching COVID-19, of course, but one of the risks is that we're at home, and most of us are working from home if we're working. And if you look behind me, the kitchen's right behind me, and one of the tendencies is you're aware that you need to get up and have a little bit of a break. One of the tendencies is to go into the kitchen and snack, and I would sort of warn people against that. That is, I think, one of the risks. We've got more time, so we've got more opportunity to exercise locally, of course. Yep. But don't fall into the trap of every half an hour when you get up to stretch your legs, you go and grab something from the kitchen, because that's the opposite of intermittent fasting. That's, I don't know if that's got a name. It's called snacking, but
yeah, it's snacking. Yes, it's well known.
It's not going to be
called snacking.
A good idea.
And
we really want to be extending the period of time between eating. We don't want to be constantly grazing.
Here's a question. When did the word snack enter the English language? Because I don't think it's a very old word.
No idea. I certainly know the word breakfast. It means to break your fast. So, so you certainly don't need, you know, I think we used to get up and we had breakfast before we went to work. Now that we're working from home, certainly there's the opportunity to delay your breakfast, and ideally have brunch or lunch. But there's certainly no need to have your breakfast at 8 o'clock or 7:30 before you go to work anymore.
No, I mean, I think the best way not to snack, I think, is make sure all your meals have a decent amount of protein in them. You know, like I think eat so you can eat protein, and if you eat like that, then you probably won't have much need for those other things that, you know, in between meals. And I also think, you know, like a good substitute for a meal, if you've actually eaten well and don't need to eat anything, is a bit of cream in your coffee or something like that, that can make you feel full and keep you going. And but, you know, staying busy, either learning or, you know, filling your head with things to think about, music and books, and that doesn't all have to be serious at all. You know, the beauty of, you know, you could learn something new. You could learn, if you hadn't already, for example, I learned to listen to classical music a few years ago. This would be a great time for that. If I was, you know, learn to appreciate something that you haven't appreciated before, or something you used to appreciate that you've forgotten about. You know, give yourself things to think about that aren't you know, the real world worries out there.
All right, George. Well, I think we should probably wrap this up now. Yeah. I thank you so much. You know, somebody involved in health, I have learnt an enormous amount, and you've also answered a lot of the questions that I've had around these topics, because, you know, we have got a lot of information from the TV, but these are the questions that I really wanted answers to, and you've answered them beautifully, and I really appreciate that. I'll have to digest some of your answers, but thank you for your wisdom, thank you for your clarity, and thank you for giving up your time to talk to us.
And thank you, Glen.